Welcome to Get Moving TV. I'm Dr. Landon and I serve as your host. Here in Ventura County, there's a number of things that really affect the world that occur, and our family medicine residency at Ventura County Medical Center is very highly rated, even up to #1, hard to get better than that. It puts out incredible residents who go throughout the world. They're in Chad and Monrovia and Guatemala and Nicaragua, and are dedicated to medicine. Sometimes we get different paths, and we've talked in the past about kind of the arc of life, and sometimes how that arc gets bent. But at all times, we're looking for justice and human justice and good health for all. With me today is Dr. Preston Arndt, who graduated from the program. Preston, welcome.
Thanks, Dr. Landon.
So how did you end up here in Ventura coming to a family medicine residency, and then we'll talk about the rest of it. How did you end up here?
Well, I grew up in southwest Minnesota in a little town called Echo, Minnesota. My family farms soybeans and corn. And growing up, I loved looking at encyclopedias and I liked taking notes. And they say what you like to do when you're a kid is what you're going to be best at when you're an adult. So research and learning about things, learning about the world more than just what's directly around me, but learning about other places, other countries was really important to me. And I always took my notes to my mom when I was 7 years old, and look what I found out, and look what I wrote. And I went through high school and got to college, Augustana College in Sioux Falls, South Dakota, got my chemistry degree there, and then went on to medical school in the University of Minnesota Duluth in Minnesota, and for 2 years, and then we moved on with the rest of the kids in the second 2 years of University of Minnesota for being on the wards. And at that time, you have to make a decision what specialty you want to do. And being Minnesota grown and really all about family and the continuum of life, and I liked a little bit about everything. I liked psychiatry and pediatrics, and I thought about medicine and pediatrics. And so I thought, well, family medicine is probably the best for me. And so what happens in medical school, to choose a residency all over the United States is what we call a match. And you can sort of think about it as a sports draft. You choose your favorite 15 programs you want to go to in the United States, and the individual programs will choose their favorite 15 medical students to hire. And fortunately, and it was one of the best days of my life, I got chosen to come to Ventura, California at VCMC, their residency program. And what attracted me to that program was the fact that many other residents that graduate from that particular program do many different things. Some of them do C-sections. They have an OB fellowship here. They have a medicine fellowship here. That's kind of what I wanted to do. I wanted to blaze my own trail. And I got through family medicine residency, and I met you, Dr. Landon. You were one of the pediatric attendings there in 2000. And I graduated with a very much a broad-based knowledge of the spectrum of disease, and from newborns up until late life. I stayed in the program, fortunately, and in the system, and started at Magnolia Clinic, which is a satellite clinic of the Ventura County Medical System. And now I have a very big practice of mostly adults, some peds, but now I mostly see chronic disease. And with that, I've gained a lot of knowledge about pathophysiology and the science of things. And that's where I like to say I like to shine, because I love to educate people. And I like to educate patients, I like to educate colleagues, and I like to educate anybody who is willing to listen to me. Because education is power. They say knowledge is power. And if you educate someone, give them knowledge, it's that much power they have over anything, their disease, and how much power they have to tell other people about what they know. And one day you'll hit the jackpot and someone will invent something because of what you said further along the road.
Well, I think the disease doesn't have the patient. The patient has the disease. And the other thing that you bring is that human part. I mean, knowing the disease is important, but having to adhere to the treatments that are needed and show up for the appointments and really do what can affect that course of that disease, that's really what being a doctor is all about. And sitting here under the burden of the electronic healthcare record and staring at a computer screen all day, it's been very disturbing, I think. So how has it interfered with your ability to be a physician, to help that patient?
In a way, yes, and technology is important. We actually use technology for adherence, but when you go back to the basics, I like to use a term called root cause. What's the root cause of something? And it's great seeing all the data on the electronic medical records and Excel spreadsheets, but it's what you do with that data and how it applies to the individual patient, which is important. When you look at root cause, you take the data and how does it apply to the patient's life? When did the disease process start in the patient's life? What caused the disease? What's causing the disease to continue despite your best efforts? An example would be a diabetes and diet. Diet's the root cause. It's not, taking your medication will make you better. It's how do you reverse the process? A root cause, let's take cystic fibrosis, for example, which is the most common life-shortening autosomal recessive disease. It's a genetic disease, but digressing a little bit, when I say that, when I talk to my patients, I like to do motivational interviewing, and I like to say that we have more in common than we have differences. Myself, I am made up of 3 trillion nucleotides, and they're little tiny things that make up our DNA. So do they. They just have a defect in just one of them. I have a defect that might do me in 5 years from now. I don't know, but it's possible. So we start out with that. And then we look at, well, what's causing your cystic fibrosis to become worse? And you mentioned adherence, and that's when it comes to CF and that's a root cause. If you're not adherent to your medication, that's a root cause of you not getting better. And speaking of adherence, we really overestimate how adherent our patients are. When you look at the research, only 30% of our patients are actually adherent to what's going to help save their life. And what's more, to keep on living until there's a cure for cystic fibrosis, because that's just right around the corner. And we also like to tell our patients that too, to give hope. Now, when you bring back the electronic medical records back into it, it's a great tool. It's a great tool for the physician because it allows us to bill. And it's all based on billing, and because we have to, survive, our hospitals and our clinics have to survive. But it can be used for so much more. Can we use the electronic medical records to teach patients? Can we use it to communicate with patients in a better way? Can we use the EMR to make physicians adhere to guidelines? And that's where I think that we can take the extra step to make it kind of physician-based and patient-based, and that connection being there. Recently, we've started a relationship with a group out of South Africa who have a business in Ireland called InfoCare. They're the same mindset that can you take data in an EMR and your regular clinic note that you have and make it come to life, make it come into action, and make it do stuff for you to help your patients. And they were able to do that for us. It all started last year. You met Dr. Daniel Stegman, who's from South Africa. And just by happenstance, you started talking about what's going on. And Daniel said, wow, I have a program that when the physician puts words in their clinic note to talk about the patient, that it will mean something. It'll be coded for use, for adherence, for following guidelines and such. Well, the relationship got better, and Dr. Landon came to me and said, hey, Preston, you got to meet this guy. And I said, this is great. At the time, I was using spreadsheets, spending hours on spreadsheets and graphs. Background behind that, being in family medicine, you're kind of thought to, you take care of infants, children, teenagers, adults that have diabetes, high blood pressure, and other of these common ailments, and also take care of acute sick problems. And then if they're beyond the scope of that, they're being seen by pulmonologists and cardiologists and nephrologists and all the ologists. And then we kind of put our hands away, but we're there for seeing them for visits, sick visits or whatever. Dr. Landon was seeing pediatrics. So he's a pediatric pulmonologist, but being that in pediatric pulmonology, asthma is a chronic disease, cystic fibrosis is a chronic disease, allergies can stay with you for the rest of your life. You can about imagine what happened when these kids turned 18. They didn't leave Dr. Landon. They didn't leave you. But recently, there's been a push towards adults being taken care of by adult trained physicians, which Dr. Landon got me to say, hey, Preston, come over here. I see a lot of cystic fibrosis adults over the age of 18, and I want you to come and see us and see what we do. So I came over there 3 years ago, and nobody knew me, and I knew Dr. Landon, but I got familiar with some of the cystic fibrosis patients myself, and started talking about the CF patients, but everybody else thought, so who's this guy? And talking about the CF, is this legal? But they got to know me, and I got to know them, and there was we built a really great camaraderie at our clinic. And with that, a lot of knowledge back and forth, and got to really know our patients. And now the adult patients, after 3 years, and with the tutelage of Dr. Landon, I've gotten to see myself as being an expert in cystic fibrosis.
Well, you're really the first family medicine physician in the United States that's been assigned to a cystic fibrosis clinic, and that's because it's a prenatal disease now, so we should get prenatal screening, and if you're at risk, you should have your partner tested. When your baby is born, we know right from birth, and we're able to alter the arc of that. And then it moves, now people are going to be 50, 60, 70 years old and have problems of osteoporosis and depression and heart attacks and smoking and drug abuse, whatever. So it moves way beyond what a pediatrician can do. And I hope a lot of times when we made that transition, it was suddenly, I'm an internist, you will take your medicine, you're not taking it, you're too bad. And that just can't be so. And so the first project I assigned to you to help you in this process of mentoring, we were, I think, the 18th percentile for babies' weight under the age of 2. And we hear about this a year after. They keep track of this. Okay, you're horrible. You really haven't So we put a project together where we did this plan, do, study, act with the aim of having the fattest babies in the United States of America. And within a year, with that kind of multidisciplinary action, we were number one. We had the fattest babies in the United States. But how do we do that with testing for diabetes? How do we do that with keeping their weight up? How do we do that with participating with these airway clearance things? So how can we use technology to help us out with that?
Well, it took a lot of time and effort on the part of all of us in clinic. With technologies, though, we can use the data that we have and then embed, I would say, back to our clinic note, for instance. Let's talk about the Soteria, this medical system that we're going to use. So Soteria is basically make an analogy. You can think of the hospital and that clinic system as a planet, okay? And then the electronic medical record is a big spaceship. And so Soteria is kind of the hovercraft between the Earth and the spaceship, going back and forth, dumping information back and forth. But Soteria is really a live artificial intelligence, so to say, clinic note. So when we do our clinic note and when the patient looks at, what are you talking about me for? Or what are you saying there? Yeah, we're talking about the history. What's your history of present illness? What's your past history? We'll review the different symptoms you might have. They might not be related to today's visit. We'll look at your vital signs, your physical examination, and then we have an assessment of what we talked about today, and then a plan of action. That's basically what physicians do in their clinic note. Right now, that clinic note is used to communicate to colleagues and also the billing department to bill for services. That's it. But there's so many guidelines we use. So there's something called the registry that the Cystic Fibrosis Foundation has. And the Cystic Fibrosis Foundation governs over about 120 core cystic fibrosis sites in the United States, plus 55 or so affiliates in the United States, making over 170 sites. And these 170 sites all have completely different systems that they use to assist in billing and keeping track and keeping notes and communicating to colleagues. So I thought, well, if there's these guidelines we have to follow, why aren't everybody on the same page with the guidelines? Because every year we get how good we are. It's called the last one was a 2015 registry report. And we, across the board, failed in oral glucose tolerance testing, DEXA scans. Many of the sites still fall below par on the body mass index, FEV1, checking for non-tuberculosis bugs. And so I thought, well, if everybody had the same system and everybody was subject to what we call quality assurance, and if there was the guidelines built into the clinic note, which we have to talk about anyhow in our clinic note, why can't we make that clinic note come to life for the foundation and keep us honest to fulfilling those guidelines? So we would be 100% accurate at the point of care to fulfill those guidelines. So when you get that registry report, we're at 80%, 90% across the board, from California to New York.
Well, that's harmonizing among all those centers, having all those centers singing together in a giant choir, but not out of tune. That every single place has that ability. To me, is very important, because the drugs that now can fix the underlying defect, they don't cost. It costs about $60,000 a year to take care of someone with cystic fibrosis in terms of antibiotics and occasional hospitalizations and so forth. And these drugs are $300,000 a year. And when we start looking at 30,000 patients with cystic fibrosis, and as we come up on the cure, if it's $300,000 a piece for 60 years, we have a $54 trillion problem in no time at all. So we need the studies. Every study, every center needs to have harmonized data so that we know that one physical exam is exactly like the other, that we're able to mine the data very, very exactly. And with time, hopefully the costs will, of course, come down. But I need my patients to move from center to center without too much change. And so much of it was the voodoo, the art of medicine. And we've certainly been sent patients who do not do well in other centers, because we have the social worker and we have the child psychiatrist, we have adult psychiatry, the things that we need as a team to take care of people who are under this stress, because it isn't a disease that has the patient, it's the patient has the disease, and there's no health without mental health as well. So what do you see going forward? So we've piloted at our place, and we've certainly made large progress. How can we progress it? How can we help all these other centers, starting here in Ventura County?
Well, I think this this sit-on-top model, the Soteria, or programs like it, when I'm sure this all comes to fruition, will be really used as an asset for development of new therapies. I think when you have an actionable note and you have all the data in there, it's much easier to sift through something organized like that at point of care rather than paperwork and charts, even if they're EMR charts. So you can search for something like Pseudomonas throughout the whole system. When was this patient last positive for Pseudomonas or negative for Pseudomonas? That's very difficult when you look at every individual EMR and try to sift through that. Many times, drug companies will, because we're a relatively small CF center, 53 active patients right now. We're an affiliate right now with Children's of Los Angeles. But a lot of drug companies will kind of pass us by and go towards more of the bigger places like USC, UCLA. So I think they're missing a lot of possibilities. We have patients that they could use. If you take the whole gamut, the 30,000 CF patients in the United States, you take away some of the smaller centers, you're missing some. But so if we are a collective and get collective data using smart documentation, artificial intelligence, how I say, clinic notes, I think you can more efficiently collect that data without spending time sifting through data.
Well, we've also done other projects like Care Message, where the patient would get a 140-character message 3 times a week that just run about nutrition and adherence and doing their airway clearance and depression and how to getting outside and really working through that. We're working on integrated healthcare coaching with 2 people outside of Montana who finally were using our FaceTime, Zoom to good use. Instead of just looking at your grandparents, now the patients with cystic fibrosis are not allowed to be in the same room together. And so now they can participate. We had one who's 14 now who had never, ever spoken to anyone else with cystic fibrosis. And here's this disease, this potentially fatal disease where there's tremendous progress being made, but is it progress for him? And he can finally ask the questions that he needs to ask that I can't tell him the answers to. We've done the adherence with the Bluetooth, putting it in their device that beats the mucus out of them, literally. We've put it in the medication delivery device, and all that can also integrate into this record, so that at the time of visit, you know whether they need assistance. We have our machine-on-machine mankind interface, which spells out mommy, because we want your mommy watching you, and we can do that with adherence. But we really found it's also important to have a human involved, and that was once a human saw the data and said, "Oh gosh, I see you're only using your medication on Friday morning. Why is that?" "Oh, I have a date Friday night." "Well, it's really 3 times a day, 7 days a week for 30 days. How about Monday, Wednesday, Friday?" "Oh, next week, sure enough, there it is, Monday, Wednesday, Friday, twice a day." "Hey, why not Tuesday?" "Well, let's see, I have lunch with my mother." "Oh, well, you could take it at 8 and noon." "I could, and Dr. Landon tells me," because he wants to take pictures of his food, make sure eating well, he sees he's getting those at midnight, and it's waking him up, but he's got nice pictures of your midnight snacks. So did you know you could take it at midnight? And after a month, we're able to do that. And by having them take their medicine regularly, these exacerbations where their pulmonary health falls apart, we can start lengthening them out and preventing these horrendous events where they're drowning in their own thick mucus. So we called that our Fostering Adherence to Help Exacerbation Reduction, or FATHER. So if your mommy can't take care of it, wait till your father gets home. So the integration of all this, where do you see it going? We have...
the integration is amazing. So you can integrate Bluetooth, distance telemedicine into this program. A good example is less mistakes would be made too. I'll tell you a good example. A couple of weeks ago, there was a patient, one of the CF patients I also see at my own clinic. I did a pulmonary function study on her. And we do PFTs to measure how healthy someone is at time and compare them to a few weeks ago to see if they're worsening or getting better. Well, these PFTs depend on a person's height and a person's weight. And if you don't put the height and weight in to the machine, it's going to give you a totally off answer. So in this particular situation, the medical assistant who does very excellent PFT, she always does A's, but she put in the weight wrong. And so we got a totally skewed answer. Her lung function went up by 10 points. And our nurse coordinator, Ann, who is amazing. I don't know how she did it, but kudos to her. It wasn't a half an hour later, and she called me, and she said, Dr. Arndt, did you know her points went up by 10 points? I'm like, yeah, it was awesome. Well, did you know she, only, is like 10 inches tall? And I said, that's impossible.
Yes.
So we went in and redid it, and her lung function dropped, and this got her admitted to the hospital.
So not overweight, but under tall. Yes.
Right. How this can be circumvented? Have Bluetooth technology with a scale. Yes. right to the program. We rely on also all this data to put into what we call the Port CF registry. And right now we have to do it manually. And with this program, I think we can do it automatically.
Well, Dr. Arndt, thank you so much. It's been mentoring you over the last 3 years because I'm, of course, looking at more of a white beard all the time. It's time for all of us to learn how to do new things and take your enthusiasm and put them in our own lives. And Ventura in particular, it's time for you to get moving.